Hello, I am the RX Psych Pharmacist. I hope you are doing well. I hope you are having a good day. And today I'm going to be talking about psychotropic adverse drug reactions. And these are unavoidable with any medication, but psychotropic adverse drug reactions have some reactions that are kind of unique to them. So we have to pay careful attention when someone's on these medications, and we have to pay careful attention to them and to look for these adverse drug reactions and modify therapy as needed. So adverse drug reactions, they're increasingly recognized as an important cause of morbidity and mortality. I think I probably have this wrong, but somewhere between like 13 to 17% of all emergency room visits are due to adverse drug reactions. That's not just psychotropics, that includes everything, including antibiotics and anti-neoplastics. Psychiatric patients, especially those in forensic units, may be at increased risk of adverse drug reactions because these are the treatment resistant patients who could be on multiple antipsychotics or mood stabilizers, increasing their risk of having an ADR. And detecting and documenting these ADRs can help us identify a pattern of who may be at risk for these ADRs, of if they've had ADR in the past to a similar drug, we can predict if they'll have a similar reaction to a new drug. And it can also just help us identify within our institution how patients are responding to the drugs we are providing them, and to make us all aware and reporting ADRs, to make the nurses, pharmacists, and doctors hold them accountable for reporting ADRs so we can all be on the lookout for them. Adverse drug reactions may be due to age-related changes, so morphological changes in the body can increase someone's risk to an ADR. Inappropriate prescribing, someone on too high a dose, or if there's a drug-drug interaction. And ADRs can be idiosyncratic. We may not know why they occur if somebody's starting on a drug. It can be rare, and sometimes it can be very serious. So what is an ADR? There are various definitions of ADRs. What is the difference between a side effect and an adverse drug reaction? Different organizations have different definitions for them, but the American Society of Hospital Pharmacists defines an ADR as unexpected, unintended, undesired, or excessive response to a drug that interferes with treatment. By interfering with treatment, they mean like changing a dose of the drug or discontinuing the drug or requiring drugs to suppress the adverse drug reaction. A side effect is really minimal and doesn't really alter treatment that much. But there are gray lines. Like, I've had prescribers tell me that they aren't sure an antipsychotic is working until they start developing extrapyramidal symptoms, adverse drug reactions. And some other definitions are like, well, that's just a side effect. Yes, we can treat the EPS symptoms, but it's expected part of therapy. So there is some gray areas. An ADR program was developed to improve the quality, my cat is here, of patient care and comply with the Joint Commission standard. Hospitals are required to evaluate, monitor, and respond to ADRs in order to obtain accreditation by the Joint Commission. We just had our Joint Commission survey, and they really liked what we were doing with our ADRs. We were collecting data and putting it on a poster, showing our research of the ADRs at the facility and which ones we're seeing and what we're doing. how many were severe, how many people got sent to the emergency room from our hospital. So there's a lot of information we can gather from these ADRs, but there's not much published data of psychiatric inpatients and their ADRs, which we will get into. 12 to 17% of all hospital admissions are due to an ADR. Overall rate of severe ADRs constituted about 1.32% of all inpatients in a psychiatric unit, and we'll look at that study a little bit more closely. According to various studies, most of the ADRs in psychiatric units are due to antidepressants and antipsychotics. It depends on what the psychiatric unit, who's their most common patient. Who do they see most? Do they see mostly suicidal patients or more schizophrenia or both? Whoever they see, they're likely going to prescribe more of those medications, so we'll see more ADRs. But we'll see those different drug classes have different ADRs associated with them. ADRs in hospitalized psychiatric patients are not only common, but they also have a high rate of preventability by identifying them and preventing drug-drug interactions or too high of doses than indicated. Those are some of the strategies where we can prevent ADRs, and basically listen to the patient's perspective as well, because the patient's input is very valuable when analyzing to see if there's an ADR. Studies vary of the occurrence of ADRs in a psychiatric hospital setting, which we'll see. ASMP study. This study looked at over 122,000 inpatients of psychiatric hospitals over the course of 7 years all across Europe. And they found that 1.32% of severe adverse drug reactions occurred. And these drug reactions, we can see they broke it down by drug class. Most were neuroleptics, but they also looked at non-psychiatric drugs. Not all patients in a psychiatric hospital are going to have psychotropic adverse drug reactions. Remember, there's a lot of comorbidity and comorbid disease states in those with psychiatric conditions. Another neat thing the ASMP study did was broke down the ADR based on body system if affected. And this is kind of how I broke down the rest of the presentation, which we'll get to. But neurologic, we see some epileptic seizures can occur. Pisa syndrome was frequently reported within this study. Pisa syndrome is like the Leaning Tower of Pisa. It's an extrapyramidal symptom. Somebody can be leaning over like the Leaning Tower of Pisa. And there's also things like rabbit syndrome where people can't stop moving their lips. Severe Parkinsonism, another extrapyramidal symptom. People are shuffling their feet, they're pill rolling, they have a tremor. And then there's ataxia, which we see as well, which is basically the loss of muscle movement. In psychiatric, toxic delirium, we see this with anticholinergic drugs, those with anticholinergic properties, we can see this. And also agitation. Sometimes this can be a symptom of schizophrenia as agitation, but it can also be an adverse drug reaction as well. Like if somebody starts an antidepressant, they may become agitated. Another thing with antipsychotics, they can actually unmask schizophrenia symptoms too, like catatonia and a paranoid hallucinatory state, somnolence, sopor, and a coma. And then dermatologic, we'll get into that more, but a lot of these psychotropics have dermatologic reactions that we don't normally think about. And there's cardiovascular, orthostatic collapse, arrhythmia, conduction disturbances, thrombosis, hypertension. All these can occur with psychotropics. And then hepatic, there's an increase in liver enzymes. We'll go through these a little bit in more detail, but we also got to be careful with suicidality. That's one of the most severe ones. Completed 0.19%. ASMP study, I'm not sure if it's the antidepressants, but you got to remember these have a black box warning that for the first couple weeks it can increase someone's risk of suicide because it gives them more energy while not necessarily relieving their depressive symptoms. So those first 2 weeks are especially be cautious around. Then there's a principle of drugs involved in adverse drug reactions from the Thomas et al. Study. And you can see here they analyze a lot less number of drugs, and I believe this study was over the course of 3 years, and they identified an ADR about 30 a year. And they broke it down between antipsychotics and non-psychiatric medications as well, which we can see here. One thing that's unique about this study that's kind of different from my hospital is they have a lot of ADRs that are from benzodiazepines. Benzodiazepines at our hospital is one of the most prescribed drugs because it works for agitation, anxiety. It's one of our most prescribed drugs, but the reporting of its adverse drug reactions is probably the smallest. So it's interesting to see it in other studies. The Thomas et al. Article also broke down what kind of ADRs someone was seeing from the antipsychotics. So, for example, second generation antipsychotics, you may see dyslipidemia because it can, especially the olanzapines and the clozapines, can increase cholesterol levels. Neutropenia, we'll break down each of these so we can get a better understanding of why we see these ADRs associated with these drugs especially. Some of these our hospital wouldn't even classify as ADRs, such as extreme sedation. Maybe we would. It depends on how extreme. Our hospital, since there's a lot of comorbidity with antipsychotic use, we may not identify dyslipidemia necessarily as an adverse drug reaction. The final data that Thomas et al. Looked at was the preventable adverse drug reactions. They identified these using the Naranjo scale. And for preventable adverse drug reactions, we can look at lithium. You know, lithium's a narrow therapeutic index drug. It requires a serum level between 0.6 to 1.2. Anything higher than that greatly increases someone's risk of having an adverse drug reaction while not seeking greater improvement. Another thing Thomas et al. Looked at were drug-drug interactions and which ones could cause which. And if you saw in my drug-drug interaction PowerPoint, we see lithium is influenced by these NSAIDs like ibuprofen and these blood pressure medications like lisinopril and hydrochlorothiazide. So it's something we have to think about when we start somebody on blood pressure medication and they're on lithium, or vice versa. So this was something interesting the study did. Then there's a Iupa et al. Article. I hope I didn't butcher it. I know I did. They report 115 ADRs between August 2007 and August 2011. 64 were classified as probable or definite. And unlike the Thomas et al. Study where it was almost like split in half, 87.5% of these ADRs were due to psychotropics. And Depakote was the most frequent, followed by haloperidol. And 9% of the ADRs, patients had to be transferred to a different medical facility. And they identified 34.4% were preventable ADRs, which is huge. It lets us know how important it is to be aware that these ADRs can occur. Most common causes of ADRs were supratherapeutic serum concentrations, drug-drug interactions, and history of a reaction. Everything we talked about. 87 pharmacist interventions were accepted, and it was a 96.5% acceptance rate by prescribers, which is really good. I wish I could get those numbers, but I don't get that acceptance rate, but that's okay. I don't know what my acceptance rate is, but as long as I provide good information, I'm happy about that. So the IUPA et al. Study, they also broke down the medications they looked at, or which were responsible for the adverse drug reactions, and they had the mood stabilizers as the highest because of Depakote, and then the second generation antipsychotics were up there too. And this is kind of similarly what our hospital looks like, mainly because we use second generation antipsychotics the most. We also have a high number of first generation mood stabilizers, ADRs. But like this hospital, we don't have many antidepressants. We don't have a lot of suicidal patients. We have a lot of schizophrenia and bipolar. Finally, IUPA et al. Looked at medications involved in prevented adverse drug reactions. I do not know how they determine whether something like a stimulant is a prevented adverse drug reaction or a mood stabilizer is a prevented adverse drug reaction. Maybe that is if somebody's out of range. Same with the antipsychotics, without therapeutic serum level range. The next study is by Bowen et al. And this study was nice because they broke down the drugs that caused the adverse drug reactions, and they said what the adverse drug reaction was based on the drug class. And we'll kind of talk about why we see these drug interactions with these drugs when we break it down by each body system. So the first body system is neurologic ADRs, which includes extrapyramidal symptoms. So conventional antipsychotics have the highest risk of extrapyramidal symptoms. So this is where you see the lip smacking, the dystonia, the tremor, akathisia, and after a long period of time, tardive dyskinesia. Clozapine has a black box warning for seizures, so we want to be extra careful if somebody has a seizure history or add something like a mood stabilizer like Depakote. We don't want to do lithium because lithium and clozapine together can cause seizures, as we saw in one patient. Depakote would probably be the better choice for seizure prophylaxis. Of the first generation antipsychotics, chlorpromazine has the highest risk of seizures. It is recommended to avoid bupropion in those with seizures, which is an antidepressant, a norepinephrine dopamine reuptake inhibitor. And then lithium has neurologic ADRs and toxic levels like tremor, cognitive dulling, raised intracranial pressure. Cialyria, which we see it a lot at our hospital because we have so many patients on clozapine, it can be also induced by other psychotropics as well, but it's kind of known with clozapine. And we treat that with glycopyrrolate. They can also treat it with benztropine or atropine drops, basically any anticholinergic. And then there's post-injection delirium sedation syndrome, which occurs in about 2% of patients administered olanzapine Relprev, which is the long-acting injectable of olanzapine. It's a every 4-week injectable. I haven't seen this at our hospital yet, but it can cause somebody to be delirious, increased risk of falls. They can become agitated, confused. So that's why they have to be monitored for 3 hours by a healthcare professional after each injection. Here is a table of the 4 most common extrapyramidal symptoms, and all the other ones kind of branch out from these kind of foundational ones. There's dystonia, which is the involuntary contractions of skeletal muscle. We see this really quick. The onset is 24 to 96 hours. And this is due to a decreased dopamine in the basal ganglia. A lot of these are due to the decreased dopamine. They believe that's what causes these EPS symptoms. And the treatment is usually a drug with anticholinergic properties like Benadryl. It's an antihistamine, but it also has anticholinergic properties. And then cogentin, benztropine. And then you can also discontinue the antipsychotic, but we have to weigh the risk-benefit of everyone on a psychotropic medication regimen. Is it worse having the adverse drug reaction, or is it worse knowing that what happened to get someone hospitalized can happen again if they aren't being medically treated with a psychotropic med regimen? And then there's pseudoparkinsonism. This takes several days to several weeks to develop. This includes the bradykinesia, shuffling feet, cogwheel rigidity, tremor at rest, and pill rolling movements. And this is caused by dopamine blockade in the nigrostriatal pathway. And this same thing, due to dopamine blockade, we treat it with anticholinergics. Benadryl, amantadine is a dopamine agonist, so it can kind of replenish that dopamine. Propranolol is a unique one, being it's a beta blocker, but it crosses the blood-brain barrier and kind of can relieve some of the tension of these psychotropic drugs are having on our brain. Or we can, again, discontinue the antipsychotic. And then there's akathisia, my favorite. And why is it my favorite? It's because I personally have experienced akathisia. I was on the medication paliperidone in Vega, and while I was taking that medication, akathisia is an error or motor restlessness. I could not stop pacing. I could not sit still. Well, then you're like, why don't you go on a long walk? And I would try that, and I couldn't go on a long walk. I would start on propranolol. I'm not sure that helped. What actually helped was decreasing the dose a little bit. I'm no longer taking it, though. I'm taking a more tolerable drug. And then there is tardive dyskinesia, which takes months to years to develop. It's involuntary, repetitive movements that are mostly in oral, lingual, and buccal regions. I've seen this twice. One was in a guy. He could not stop twisting his neck around or stop moving his tongue around, and the same thing I saw in a woman as well. There are multiple theories of why this occurs, but people mostly believe it's due to long-term dopamine blockade. And this condition, unfortunately, can be irreversible. The things they recommend to do is discontinue the antipsychotic or to switch to clozapine. Clozapine is less of a dopamine blocker than the other antipsychotics, so is less likely to cause extrapyramidal symptoms and also exacerbate tardive dyskinesia. And then there's Ingrezza or valbenazine. It's a specific drug. Its specific FDA approval is for antipsychotic-induced tardive dyskinesia. It's like a VMAT1 inhibitor. I'm not too familiar with its mechanism of action. It's so new, and we don't carry it at my hospital. But There's also ginkgo biloba, which is one of the most studied treatments for tardive dyskinesia. And there's vitamin B6 as well, which can help. Clonazepam can help too. It's studied a lot as well for tardive dyskinesia. Then there's dopamine 2 agonism and the acetylcholine and EPS symptom kind of regulation. Dopamine normally suppresses acetylcholine activity. So when you have a dopamine blocker, you aren't getting the dopamine, so you can no longer suppress the acetylcholine activity. So they believe the mechanism associated with the production of extrapyramidal symptoms is too much cholinergic activity. This is why anticholinergics are used to overcome the excess acetylcholine activity and to reduce extrapyramidal symptoms. There's psychiatric adverse drug reactions as well. Potent anticholinergic drugs like clozapine and olanzapine and thorazine, they can cause cognitive effects, slurred speech, mental slowing, delirium, especially in the elderly. The antidepressants like tricyclic antidepressants like amitriptyline, clomipramine, and also the serotonin, selective serotonin reuptake inhibitor paroxetine. These are anticholinergic as well, and you can see these with those as well. Paroxetine, it's not as strong as an anticholinergic, but of the selective serotonin reuptake inhibitors, it's the most anticholinergic one. Antihistamine or anticholinergic drugs can cause reduced initiative, interest in the environment, or even a flat effect. Nervousness or agitation is also a common symptom of many psychiatric disorders, but can be caused by activating antidepressants like Prozac. Mania can be precipitated by serotonergic drugs like antidepressants, selective serotonin reuptake inhibitors, serotonin norepinephrine reuptake inhibitors. We already talked about antipsychotics can unmask symptoms of schizophrenia. Impulse control disorders is another side effect of many antipsychotics. For example, aripiprazole has a warning that it can increase pathological gambling. And let me tell you, this is so true. I was on Abilify for maybe like a couple months, and during that couple months, I was gambling. I was going to the casino, and one time I went to a casino, I went into a no hold'em poker tournament. Is like $100 buy-in, and I lost on the first hand. And I never liked gambling, but on Abilify I did. I never went back to that casino. I was just so disappointed in myself. And psychotropics can affect sleep schedule. You can see like psychotropics have antihistaminic activity, which can, like Benadryl or these other antihistamines, can cause someone to be super sedated. There's also psychotropics that we use if somebody has insomnia, like Ambien, trazodone, sometimes used for insomnia, mirtazapine, an antidepressant, is used for insomnia. So we have tools that we use to benefit the sleep schedule. Some drugs can also cause insomnia, like the activating ones like Prozac. And then there are the dermatologic adverse drug reactions of psychotropic drugs. A lot of psychotropic drugs, they have elimination route like a lot of other drugs through the sweat. So that's why we can start to see dermatologic side effects like hair loss, acne from these drugs. But I'm going to point out some of the unique features of some of these drugs. There's carbamazepine. It has a black box warning for serious dermatologic reactions for those with a HLA-B1502 allele. So this is another example where genetic testing can come in handy, is if we're considering starting somebody on carbamazepine, we gotta test them for this allele. And we see this allele most often in, I believe, some subgroup of an Asian population. Then there's lamotrigine, which has to be dosed really carefully and really slowly. We have to start slow and work our way up. And if any rash breaks out, we have to discontinue it because it could be Stevens-Johnson syndrome, which can be a typical fatal event that symptoms start with rash and then it can progressively get worse and the skin starts to slough off, so it can be serious. Lithium can cause acne, psoriasis, and hair loss. And let me tell you about lithium. I used to be on lithium as well, and with this drug, as soon as I started it, my butt started breaking out with acne, and it was painful acne. When I sat down, my acne on my butt hurt me. So, needless to say, I didn't stay on that drug too long. I was within therapeutic levels. Don't get me wrong, it's the gold standard, and it helps a lot of people with bipolar maintenance disorder. But it does have some side effects to it. And then there's lamotrigine again. We have to worry about the rash. Many psychotropics, like other drugs, can cause skin and subcutaneous tissue disorders. And skin pigmentation can actually occur due to dopamine melanin conversion in all less potent neuroleptics. So you may see this with chlorpromazine, especially. You may get like a bluish color. And then Geodon can cause DRESS syndrome, which stands for drug rash with eosinophilia and systemic symptoms. This is another severe dermatologic. It's a hypersensitivity reaction, and it's lethal in 10% of cases. And photosensitivity with severe sunburn with antipsychotics, it gets excreted through the sweat, and it can make our skin be more prone to burning. Here's a table of some of the common second-generation antipsychotics and also Haldol, and what category of skin reaction they could have, or they have been associated with. So with itching, pruritus, you see risperidone, olanzapine, Seroquel, quetiapine. Fixed drug eruptions, we can see these. Photosensitivity, drug-induced pigmentation, we see that. Alopecia, hair loss. Women at our hospital complain of hair loss, and we do our best to prevent this by decreasing the drug. Hyperhidrosis. And there's also a table like this for antidepressants. A lot of antidepressants share these side effects with antipsychotics and mood stabilizers as well. And then there's the ophthalmologic adverse drug reactions. And I know what we're thinking, like, how can psychotropics affect your eyes? Well, they can. There can be exacerbation of glaucoma in psychotropics with the anti-muscarinic properties. Anti-muscarinic properties in itself can cause blurred vision or worsen someone's eyesight. And there are case reports that show numerous ocular adverse drug reactions, such as cornea lens pigmentation, whitish-brown granular deposits due to photosensitivity, which could potentially lead to blindness or worsening vision, such and retinitis pigmentosa, which can cause blindness. And you see that with thyroidazine doses greater than 800 milligrams a day, or chlorpromazine. Then there's lens changes or cataract development have occurred with long-term use of Seroquel and cariprazine. And actually, ophthalmologic guidelines, the optometric clinical practice recommendations call for an annual comprehensive eye exam while on some first-generation antipsychotics. And that's the optometrist's recommendation, so they see it more. There are also respiratory side effects of psychotropic medications. This includes benzodiazepines, which may boost someone's pneumonia risk, especially in the elderly. Benzodiazepines interfere with the closure of the esophageal sphincter, which can lead to aspiration of fluids in the stomach and gain into someone's lungs, causing aspiration pneumonia. Antipsychotics can do this as well. We try to avoid clozapine with benzodiazepines because of this. It can have a synergistic risk of this esophageal dysmotility. And there's also a warning of this in our electronic health record system of the drug interaction between benzodiazepines and antipsychotics. Loxapine is kind of unique. It's the only antipsychotic that comes as an inhalation form and has a US box warning of bronchospasm as well. So it has a REMS program too because of this bronchospasm. We don't use that at our hospital. This, of course, is only used for emergency use if somebody's acutely manic or agitated. We at our hospital use injectables for that, usually like a Haldol, Ativan, Benadryl combination, or a Geodon Benadryl combination with Ativan. One thing to note, though, is we don't use olanzapine intramuscular with benzodiazepine intramuscular. This is contraindicated. It can cause respiratory depression and could kill somebody. So those two have to be given within an hour apart. Oral's fine, but injectable is contraindicated. But anyway, loxapine, it has a REMS program where someone has to be monitored for 10 minutes after they get the loxapine inhalation. Cardiovascular adverse drug reactions. QTc prolongation is highest with thyroidazine and Geodon of the antipsychotics. And of the selective serotonin reuptake inhibitors, it's citalopram. Thyroidazine has a black box warning for QTc prolongation. It's important to get EKG done if there is suspicion that a patient may have cardiac conduction abnormalities, because a lot of psychotropic drugs can alter the EKG in different ways. Blood pressure can also be affected by psychotropics and should be monitored for high-risk drugs and high-risk patients. The norepinephrine reuptake inhibitors such as Effexor, duloxetine, desvenlafaxine, all have the potential to increase someone's blood pressure. On the other hand, some psychotropics with alpha-blocking properties can decrease someone's blood pressure and cause orthostatic hypotension. Potent muscarinic receptor antagonists can lead to serious anticholinergic side effects such as tachycardia. We have one patient who could really benefit from cogentin. He has a lot of pseudo-Parkinsonism and tremor, but he can't take cogentin because he says he gets tachycardia really bad when he takes cogentin, and cogentin's an anti-muscarinic, a potent one to help us combat these extrapyramidal symptoms, but you would see some patients can't tolerate it. Clozapine has a number of black box warnings that are cardiovascular in nature, including orthostatic hypotension, bradycardia, syncope, myocarditis, cardiomyopathy, and mitral valve incompetence. It's important if somebody's on clozapine to get regular cardiovascular monitoring from a cardiologist. I had someone tell me once, I haven't noticed it or read any studies about it yet, but anecdotal, this prescriber told me that when he sees people die from clozapine, out of all its black box warnings, it's usually cardiovascular in nature. There is also association between psychotropics and venous thromboembolism. It's small, it's not very large. It can happen with antidepressants. It can happen with psychotropics, antipsychotics as well. But it's kind of hard to distinguish the significance because somebody who's depressed or someone with schizophrenia, they could be more sedentary or work out less. But I know some of these studies even control for that, but the significance is small, and there is no prophylactic treatment we need to avoid it. The risk just isn't that high, much higher. Then there's the hepatic adverse drug reactions or your liver. Some psychotropic drugs are contraindicated in hepatic disease, and others have hepatic dosing based on the Child Pugh score, which is basically just a measurement to let us know how your liver is functioning. For antidepressants, you want to consider Lexapro and avoid duloxetine and bupropion. Valproate can also increase your liver function enzymes and cause hyperammonemia. Hyperammonemia can be increased, or ammonia levels can be increased without the increase of liver function enzymes. And hyperammonemia can be severe. It can cause cognitive changes. It can worsen dementia in patients who already have dementia. It can cause behavioral changes, agitation, and increased LFTs means a decreased liver function, so someone can develop jaundice or have edema. The hyperammonemia is managed by levocarnitine and lactulose. There's increased LFTs that are also seen in second generation antipsychotics as well. So we just not as prevalent as with Depakote. Cholestatic jaundice is most commonly seen with chlorpromazine. Depakote has a black box warning for hepatic failure and also pancreatitis. Nifazodone, which I don't see much at all, also has a black box warning for hepatotoxicity. I don't think it has much greater benefit or it's unique in any way compared to the other antidepressants to derive more benefit to make up from its toxicity. And then there's hepatically metabolized benzodiazepines are contraindicated in severe hepatic impairment, like Klonopin. For urologic adverse drug reactions, some drugs are renally dosed based on their package insert, and this is because the drugs are eliminated either completely or mostly renally, left unchanged. So if somebody has renal impairments, these serum drug levels may raise to an intolerable level and someone may exhibit some side effects. Lithium is also renally dosed, and I would say should be completely avoided in somebody with kidney issues. Lithium can cause nephrogenic diabetes insipidus and tubulointerstitial renal disease. I was talking to somebody once about lithium, And she was telling me she's been on it 20 to 30 years, and now she's on dialysis. And she said if she would have known the renal toxicity of lithium 20, 30 years from now, she wouldn't have ever taken it. But I think it's important that if somebody's on lithium, if it's helping them, to continually get their kidneys checked and to make everything is functioning normally. This patient also said that her prescriber abandoned her, and she was seeing no one for a long time, so she may have not gotten her lithium levels checked either. Sexual dysfunction and selective serotonin reuptake inhibitors occurs in 30 to 60% of patients. Paroxetine may be slightly higher than others, possibly due to its anti-muscarinic properties. Usually if somebody has sexual dysfunction from an SSRI, they say start them on bupropion, and that will reverse the sexual dysfunction from the SSRI, or to change the SSRI to bupropion. Psychotropics and antipsychotics as well can also cause sexual dysfunction, just like the antidepressants, possibly due to their dopamine blockade, anticholinergic properties as well. Urinary retention occurs with all antidepressants and some antipsychotics. And we have patients at the hospital who are incontinent. It could be overflow incontinence from the anticholinergic blockade, or it could be due to serotonin working on a receptor that influences the urinary tract, or dopamine influencing the urinary tract, causing urinary retention. A number of antipsychotics are associated with urinary incontinence. It occurs within hours to weeks. Psychotropics have variable occurrence of sexual dysfunction. In conclusion, that is. And here is a table I found. It describes the management of the antipsychotic and how we should dose it in hepatic or liver impairment, and how we should dose it in renal or kidney impairment. And this is just to show you that there are dose recommendations based on someone's liver functioning or kidney functioning. There are also hematologic adverse drug reactions. Carbamazepine has a black box warning for aplastic anemia and agranulocytosis, and clozapine even has a REMS program for agranulocytosis, which basically just means it's risk mitigation. So a patient on clozapine has to continually get their neutrophils checked to make sure they don't become too low, increasing the risk of a patient having a deadly infection. Agranulocytosis occurs with clozapine, but there's less than a 1% incidence. There's a higher risk in the first year with increased risk in females, older adults, and polypharmacy. There are case reports with other second-generation antipsychotics and antidepressants. And actually, package inserts of some of the antipsychotics will say to discontinue the antipsychotic if their neutrophil count falls below 1.0. And clozapine, again, is contraindicated with carbamazepine. There can be impaired platelet aggregation with some selective serotonin reuptake inhibitors, and this can interact with warfarin and increase someone's risk of bleeding if they're prone to bleeding. Anemia, eosinophilia, neutropenia, and thrombocytopenia are all examples of different hematological abnormalities that can occur due to psychotropics. Lithium can cause benign leukocytosis, and actually I've heard some prescribers use lithium in its adverse drug reaction of benign leukocytosis to increase the neutrophils of someone on clozapine who may have agranulocytosis, or if somebody has low neutrophils on another antipsychotic and need them raised. So FDA warns of risk of hemophagocytic lymphohistiocytosis linked to Lamictal, which is basically a warning that just came out a couple years ago. The incidence is very rare, but it can be deadly. It's where somebody's own macrophages starts attacking and identifying someone's own tissues and body organs as foreign and can destroy them, and it can be lethal. Here is a chart of the clozapine absolute neutrophil count monitoring and treatment guidelines. The BEM population, that stands for benign ethnic neutropenia population. And these patients are African American, and some African Americans may have a baseline lower level of neutrophils. And that doesn't mean they can't take clozapine. They just have different monitoring requirements, such as if somebody has mild neutropenia, 1000 to 1499, in the general population, it's risky, but hey, we'll take the ANC 3 times weekly until greater than 1500. But in the benign ethnic neutropenia population, it's okay. Continue therapy as is. But in general, for neutrophil monitoring, we monitor every week for the first 6 months of therapy, and then for the next 6 months, we monitor the ANC every 2 weeks. Then after 12 months, we can move it down to monthly. There are also gastrointestinal side effects. Constipation risk is greatest with clozapine, and at our hospital, everybody that's on clozapine, and even everybody at the hospital, since patients are very sedentary, they're on a bowel prophylactic regimen, which includes Docusate, Miralax. Those with severe constipation, they'll be on Senna. Ileus and bowel obstruction is another box warning of clozapine, and it can occur in approximately 0.3% of patients prescribed clozapine, and this can be very serious, causing somebody to get a piece of intestine removed, or it can become very serious and lead to death. Lithium can cause GI issues as well. Nausea, vomiting, abdominal pain, loss of appetite, and diarrhea, especially when it becomes over that subtherapeutic range. Of the SSRIs, diarrhea is most common with sertraline and is less common with paroxetine. Constipation is a common adverse drug reaction with psychotropics, and as we talked about with a prophylactic bowel regimen already. Nausea, diarrhea, and anorexia, these are side effects that I saw can be managed somewhat by taking medication with food or shifting dose to bedtime. So I can understand that with the nausea and taking it with food. And shifting dose to bedtime, I guess it'll just move the symptoms to at night so they won't occur during the day. We are on the metabolic, endocrine, and electrolyte side effects. Weight gain we talked about is the highest in olanzapine and clozapine, and also the phenothiazines like thorazine, fluphenazine. There are two reasons behind this. They believe it's due to the antihistaminic properties, and also cardiometabolic issues have been associated with serotonin 2C blockade as well. So in conjunction with lipid in conjunction with weight gain, there's also lipid abnormalities and glucose intolerance. And I'll be honest right here, I've been on olanzapine before, and I gained a lot of weight. There is debate concerning, does olanzapine just make someone more hungry, or does it actually cause weight gain? But let me tell you, there is a study that shows even one dose of olanzapine decreases the body's rate of eliminating sugar from the bloodstream. So it can decrease the metabolism of sugar in the bloodstream. Just one dose of olanzapine. So I can see how it can increase the risk of diabetes as well. Hyperprolactinemia is more likely to occur with antipsychotics with higher affinity for dopamine 2 receptors. So like you have your first generation antipsychotics, which have high dopamine blockade. And of the second generation antipsychotics, they kind of have the partial serotonin blockade, which counteracts hyperprolactinemia, but can still occur with, say, risperidone on paliperidone. Hyperprolactinemia can lead to gynecomastia, breast development in men. It can cause galactorrhea or milk production in men and women. It can decrease sex drive in men and women, and it can also cause women to not have their period. We had a patient come in the hospital who had delusions, and she had a delusion that she was pregnant, but she had high prolactin level and she wasn't having periods. So there was some kind of ground to the truth. Of the antipsychotics, the ones with the least risk of hyperprolactinemia is clozapine and Seroquel, because they don't have that strong dopamine blockade. Hyponatremia is a serious adverse drug reaction of various psychotropics. They give it a warning with selective serotonin reuptake inhibitors. It's rare, but it can potentially be deadly. It can lead to seizures, cognitive changes, behavioral changes. When the body has too low of sodium in its bloodstream, then bad things are going to happen. Another cause of hyponatremia is with schizophrenia. They can develop a disorder called psychogenic polydipsia, where they nearly have an unquenchable thirst and they just drink and drink and drink so much water they develop hyponatremia and it can kill them. We actually have that problem relatively frequently at the hospital. We have like 3 patients who've had psychogenic polydipsia diagnosis. Lithium requires thyroid and creatinine monitoring for thyroid function and to test the kidney. They recommend thyroid and creatinine levels every 6 months. Some prescribers may do it every year, but lithium can cause hypothyroidism, which can cause weight gain, dry skin, low energy, depressed mood, and it can also lower your creatinine or raise your creatinine level, making your kidneys so they can't excrete the creatinine. But yeah, a lot of times when patients are admitted acutely to psychiatric hospitals, they'll test their thyroid, especially if the patient is having depressive symptoms. They want to rule out if they have hypothyroidism. Hyperthyroidism can be a cause of psychosis, so we can rule that out as well. Poikilothermia or temperature dysregulation can increase the risk of heat stroke or hypothermia. So if somebody is on psychotropics and they're working out outside, they may not be able to sweat as much, or they can become hypothermic sooner. Their body may not respond to warming them up and giving them shivers. So that's something we have to think about. At our hospitals, we get heat advisories, and patients are not allowed having outdoor activities. And this is potentially a clinical reason why. Cyproheptadine is kind of neat because it's a anti-serotonergic agent, so it counteracts the serotonergic agent, and that's its method to reduce some of these symptoms. It's also an antihistamine as well. Discontinuation syndrome is an adverse drug reaction that can occur if somebody stops their psychotropic medication too abruptly or doesn't decrease their dose with a taper. The risk is higher for agents with a shorter elimination half-life. Like, for example, duloxetine. I know a guy who was on duloxetine for his depression, and he didn't like the way it made him feel when he stopped the medication, but he liked it when he was on it, but he stopped it abruptly because he didn't like the way he felt when he wasn't on the medication. And this is a classic example of discontinuation syndrome. It has a short half-life. He's getting pins and needles. He's getting stomach upset, and he's having cloudy thinking. And he says this is why he doesn't want to be on duloxetine. It's because he feels his body is chemically dependent on it, which it's not. It's just a withdrawal symptom of a drug that has a short half-life. Another thing that can occur is rebound psychosis. If somebody stops their antipsychotic right away, they can abruptly come back into psychosis, or depression if they stop their antidepressant too quickly. If one of these drugs has anticholinergic properties and that's stopped abruptly, it can cause rebound cholinergic effects, which can include psychosis, insomnia, agitation, and these drugs with alpha-blocking properties, and if they're stopped abruptly, they can have rebound adrenergic effects, which can cause high fast rate, high blood pressure. So it's always smart to be careful when deciding on a plan to decrease somebody's psychotropic med or to stop it completely, to taper it slowly and monitor for symptom improvement or symptom decompensation, and also monitor to make sure there's not any adverse drug reactions because of it. And symptoms of discontinuation syndrome are not specific and include headache, nausea, insomnia, irritability, and hypertension. And here's a table I found that kind of goes over the primary symptoms of discontinuation syndrome, and that's there for your reference. Here is a chart. We talked about a lot of the adverse drug reactions for psychotropic drugs, and this is a chart that gives the boxed warnings of psychotropic drugs. It's what a boxed warning is what the FDA recommends as a potentially life-threatening, extreme adverse effect of a medication that's been associated with this medication. So this is a table that shows the drugs that have the box warning and what the box warning is. And we talked about some of these. Increased suicidality risk, we talked about a little bit. In young adults, it's important to point out that there has been 0 deaths reported of increased suicidality in young adults taking an antidepressant, but there have been measures on a suicidality test saying, okay, this person is at increased risk for suicide. But there have been 0 deaths associated in young adults with antidepressants. And finally, based on somebody's adverse drug reactions or clinical condition, we can recommend a first-line treatment of an antipsychotic for them that would be better for them. This isn't clear cut and dry. There's a lot of gray area, and psychiatry is like an art, so we gotta make it patient specific. Every patient is different, and we're painting a picture that the patient can tolerate and improve on. Medication combined with psychotherapy can really help a patient, and we can't just settle and treat a patient just on their clinical condition. We can't pick a drug based on their clinical condition. We have to pick one that works for them. So, in conclusion, I know this was a long journey, and I thank you if you stayed with me through the whole thing. I appreciate any feedback or any questions you may have that I can help you with. But in conclusion, improving performance and recording of adverse drug reactions plays an important part in reducing the risk of future ADRs. It can help us develop a plan of action if we see an ADR, if a nurse sees an ADR, what's the process and how to report it and how to get the doc's attention and how relevant it is. And also, it takes a team effort to determine the probability that what the patient is experiencing is an adverse drug reaction. So it's a team concept. And it's important for patients to report their adverse drug reactions as well. It's so key to include the patient as the treatment team. It really improves outcomes. It really helps adherence to therapy. And it's just a better experience for the patient with the healthcare system. But patients in forensic psychiatry units do have an increased risk of ADRs, and they may not be making something up when they say they have a problem with an ADR. 50% of patients questioned gave a history of ADR in one study. Monitoring for ADRs is a necessity and an integral part of patient management. There are so many other ADRs out there that we couldn't get to that I wasn't even sure about, like hunchback. I've been told kyphosis is a syndrome that can happen if someone is on long-term use of antipsychotics. Fat redistribution could be a cardiometabolic system type adverse drug reaction, but there's so many out there that we didn't have time to cover them all. And this isn't to stigmatize psychotropic drugs like, oh, psychotropic drugs have all these problems. All drugs have adverse drug reaction. These are just the ones we should know about if we're working in the mental health field or treating a patient who's on psychotropic drugs, or if a patient just wants to learn more about psychotropic drugs and is thinking about starting a psychotropic drug regimen. What are the good and bad things we can tell them about? What is the benefit to risk ratio? All right, well, that does it. Have a good day.